clinical webinar. It's hosted by Royal Marsden Partners, the West London Cancer Alliance. For those that don't know me, I'm Dr. Lindsay Williams. I'm the GP Cancer Lead for Brent and Ealing. And I'm really pleased today to be joined by John Butler, who's a consultant gynaecological oncology surgeon, and he's chair of our Gynaecology Cancer Working Group at RM Partners. Thank you, John. Just a bit of housekeeping. Please can everyone keep themselves muted to avoid any background noise. If we can switch off videos, that would be great to help with the bandwidth. And you'll see a chat function. We're very happy for you to use that for questions. We want this to be as interactive as possible. We have some case studies coming up at the end. And of course, raise your hand to ask some questions. We're going to be recording this webinar, and all the slides and the recording will be sent out to you. And please feel free to ask any questions and comments as we go. We really want this to be nice and interactive. At the very end, there'll be an evaluation link. Please do complete that for us. It just helps us build on further webinars for you all. Oh, great. And we have a slide to show you how to raise your hand and where to put questions in the chat. Thank you. So next slide. So just the aims of the session. So today we're going to be talking about gynecological cancers. We're going to look at the referral criteria. We're going to review some stats. I'll try and keep it light on the data, but it's always helpful to look at the data and know how to use that for us. And so it's going to be looking at North West London by trust and diagnosis of cancers, and then the extent of which gynecological cancer is detected at the early stages. We're just going to look at screening as well. And then, as I mentioned, we've got some great case studies coming up to help with our learning. And I'm going to look at the cervical screening programme and some resources that we've collated into one spot for us so we can use that moving forward in our practice. All right, I'm going to hand over to John Butler now.
Super. Lindsay, thank you so much, and good afternoon, everyone. It's really great to be here. I'm a gynae-oncologist at the Royal Marsden, and I'm chair of the Pathway Group. It's great to have Neil Watson on the line, who's was my former boss and leads the Rapid Access Service at Hillingdon. I think certainly hearing what things are like across both primary care and secondary care services hugely challenged, and we're currently trying to do some work to try and improve the 2-week wait referral process and what can be done. So I'm going to just provide some headline background about gynae cancers, and then we'll discuss some issues about the referral criteria, but really very keen to get sort of input and comment about that as we go along. So if we can go to the next slide, and again. So just to review the cancers that we're talking about, there are 5 gynae cancers, and we've seen over the last, I qualified in 2000, so over the last 20 years, huge advances in the management of these. I would say particularly for ovarian cancer, where we've seen survival rates increasing from around about 20% up to now around about 50%, as our understanding of both the biology of the disease improves, but also better treatments. Next slide, please. So in terms of the most lethal cancer, ovarian cancer accounts for almost 8,000 cases a year in the UK and 4,000 deaths, 10-year survival of 35%, and around 10% are probably preventable. And the preventable cases are, broadly speaking, those that we might be able to prevent through more BRCA screening. So now all patients with ovarian cancer are having BRCA tests, but also something called HRD testing, which is to look for BRCA-like changes in their ovarian cancer. And by looking at the families of these BRCA patients, we're able, for many of them, to offer risk-reducing surgery to remove particularly the fallopian tubes, which are the main source of ovarian cancer, but also the ovaries when childbearing wishes are complete. And we know, and we'll discuss this when we go on to the next slide, please, that ovarian cancer was historically known as a silent killer. However, when we've looked at population studies of patients diagnosed with ovarian cancer, we know that there's a whole variety of symptoms of which you will be familiar that may indicate ovarian cancer. One of my slight bugbears, and we'll come on to this when we discuss CA125, is thinking that these symptoms are just to do with ovarian cancer. They are, broadly speaking, symptoms that may represent abdominal pathology, both benign and malignant. So, I mean, I think one thing it's important to bear in mind is even if patients have these symptoms and they have normal scans of the ovaries, it doesn't mean anything is going on. Most patients are diagnosed with advanced stage disease, as you can see in the bottom picture, and this is probably because the disease starts in the fallopian tube and rapidly disseminates to the peritoneal cavity, whereas conversely, the true ovarian cancer, which starts in the ovary, often presents with larger masses, which are more straightforward to resect an early stage. Next slide, please. So uterine cancer is the most common cancer, gynecological cancer, associated with excellent survival. And this is due to the fact, as you know, most of these patients will present with postmenopausal bleeding. We'll discuss it hopefully in the referral criteria, but there's quite a bit of discussion as to which patients should go forward to rapid access referral for potential endometrial cancer if they have heavy bleeding. But for most of these patients, they'll present with postmenopausal bleeding. About a third of them are preventable, and that's due to the obesity epidemic causing most endometrial cancer due to excess exogenous estrogens. We've seen great advances in endometrial cancer management, particularly the increased rates of keyhole laparoscopic or robotic surgery to offer these patients overnight or even day case surgery with high cure rates. Next slide, please. So cervical cancer, we're going to talk quite a bit about cervical screening today. We see around 3,000 cases a year in the UK, and almost all of these are preventable through attendance to the screening programme and appropriate colposcopy referral. Survival on the whole is good, particularly if the disease is picked up early. But the key challenge in cervical cancer is, number one, making sure the vaccine rollout is effective, but also increasing attendance at for cervical screening, and I know Lindsay's going to present some data on that. And next slide, please. So cancer of the vulva, this accounts, it's an area of particular research interest of mine. It's around about 1,000 patients a year. Most of these are older patients, but we are seeing an increased incidence in younger patients, particularly associated with multifocal disease on the background of HPV. It's very important that patients, particularly with lichen sclerosis, if they're not able to self-examine, particularly if they're obese, that ideally they do have a checkup once a year and aware of any new lesions. And final slide, please. So vaginal cancer is very uncommon, only around about 200 women diagnosed each year. Most of these are associated with HPV infection when women have had multifocal HPV and vaginal changes secondary to this, but also some patients if they have immunocompromise. Great, so that's just a bit of background about the gynae cancers. I'm not going to go too much into the treatment side of things, and we're going to have a bit more discussion when we come to case studies and referrals. So Lindsay, back to you to discuss some data on the 2-week wait referrals.
Thank you. So firstly, we're going to look at the 2-week wait referrals. So this first slide shows you the volume of 2-week referrals that were GP initiated and consultant upgrade. So over the course of last year across all of the hospital trusts in North West London, so there's whole of North West London stats. So you'll see that the 2-week wait performance targets were initially met at the first quarter, but then as you'll see, it slowly dropped off under to the target. But looking at the referral trends over the past few years, unfortunately, you can see that performance has been struggling to reach that 93% target since last summer, maybe due to increased levels of patients being seen, perhaps. Next slide, please. So conversion rates. So the first table at the top will show you the number of cancer diagnoses, not necessarily gynae cancers, that were detected following a 2-week referral. That includes the screening, so those picked up from screening, and those GP initiated. So that's total GP and screening. And then underneath, you've got the second and third tables, which adjust the referrals via screening. So you can see the conversion is 2.4 in 2021 and 2.2 conversion 21-22 from screening. So you can see that screening does convert. So the importance of cervical screening, and I think we're going to talk about that a lot throughout this presentation. Next slide. The emergency presentations, I really dislike these slides. So this one illustrates the proportion of all gynae cancers that have been diagnosed late in emergency presentations. You can see it's still proportion of patients presenting as emergencies and have pretty much remained stable throughout the few years. So it hasn't increased, at least, but hasn't really decreased either. Next slide, please. Okay, now this slide is by borough and place. So the long-term plan specified that 75% of all cancers would need to be either diagnosed at stage 1 or 2. That's a big ambition with the screening, and particularly cervical screening will be a vital tool in early detection. So the Royal Marsden Partner data suggests that the majority of cancers diagnosed via screening are early stage. So, for example, in 2017, you'll see 90% of cancers diagnosed in North West London via screening were early stage. So that's great, 90%, compared to the 26% of cancers diagnosed via emergency presentation. So ideally, screening should diagnose the pre-invasive disease, so before a cancer has been diagnosed. But by increasing uptake as part of cervical screening, we could increase early detection rates and improve survival outcomes. So it's particularly focusing on those that have not participated in the screening programme for some time or not at all. They're the real cohort that we would like to try and engage with. And although you'll see from the table below, there are some anomalies. So if you look at each borough and the early cancer detection, I think we might need to further deep dive in this. For example, look at Hammersmith and Fulham, and they have a relatively high early detection. But then, and that's higher than RMP and higher than London average, but they have one of the lowest cervical screening rates in North West London. The two don't quite match, but then you'll see West London has the lowest detection rate, but then also has the lowest screening rate in North West London. So I do think we need to understand a little bit more about this data, because you could make some assumptions then they wouldn't quite carry for the other boroughs. But it's always helpful to see, but I thought it'd be useful for you, but to also see that there's anomalies in interpreting this. I will hand back to John to look at the referral form.
Great. I'll just pick up a little bit on that data. So I used to, for 18 months, was advisor at the Department of Health, looking at a lot of national cancer data, and I think there are different ways of cutting this, because ideally with cervical screening, we want a reduction in incidence of cervical cancer. And one could argue that any cancers that you detect through the cervical screening programme is a failure of screening. So if we just look at the stage distribution alone and not incidence, we may be missing things. What I think, and you alluded to it, is very powerful, is the patients who are diagnosed through emergency presentation. And we know that the patients diagnosed through emergency presentations tend to be those with more advanced disease, the older patients with shorter survival. So those often represent patients who there may have been opportunities either through the patient presenting or early referral to avoid the emergency diagnosis. And there's a different picture across the cancers. Ovarian cancers, it varies by borough, but up to a third of patients are diagnosed via emergency, whereas for vulval and endometrial cancer, it's very low at less than 5%. And the other thing about the staging data, and why I think that the government target isn't necessarily achievable, we know now, say in endometrial cancer, I'm always doing sentinel lymph nodes, which means I'm looking for very early signs of disease in lymph nodes we didn't usually remove. So I'm picking up a lot of stage 3 disease that we would never have known about before. We're doing more PET scans. So the more accurate we are at staging our patients, we get better outcomes for those patients, but the staging distribution may be adverse. So it's looking at all these different things, so the stage distribution and the incidence in the round, to ideally improve survival and reduce incidence. Okay, so if we go on to the next slide. Okay, and again. So this is where I would really welcome some comment. We as I know it's great to have Neil online. I don't do rapid access clinics, but I've been part of lots of conversations about revisions of this form. And I know that rapid access services are absolutely overwhelmed at the moment with what's deemed to be inappropriate referrals, and we've been trying to improve this form so that more patients with a potential cancer diagnosis go to the go to the rapid access clinics, and those with an unlikely cancer diagnosis don't. The background to the 2-week wait forms comes from NG12, which was the NICE guidance on risk of on referrals for cancer. And broadly speaking, if a symptom had a 3% risk or greater of being a cancer, then it was felt that was a red flag symptom which should warrant rapid access referral. Neil, I don't want to pick on you. I don't know if you're in a position to speak, but if you are you able to comment a bit on? You've kindly let me know about the challenges you've faced recently in your services. Do you want to comment a bit on what it's like on the ground from our side, from the side, and then perhaps?
I can, John. So just today, I had 10 referrals for us to look at, and of those, 3 of them were for valval cancer in premenopausal women who probably had Bartholin cysts or whatever, and that is just putting huge pressure on us to be able to look at the ones that are. So valval cancer is a disease mainly in the postmenopausal woman. So just that's just a highlight of some of the aspects. So this year we've had over sort of 300 downgrades on the rapid access patients coming into our clinic, and we're still struggling to see the ones that aren't downgraded. The issue is that any downgraded ones have to be seen by us within 2 weeks. So it then puts quite a lot of pressure on the gynae services as well. So we've got an extra clinic running just to take down on the downgraders, in essence, to do that. So it is a big pressure, but I understand from the GP's point of view, if you've got someone who you're worried about and you want them to be seen quickly, then you tend to send them in that way rather than necessarily an urgent gynae referral.
Many thanks, Neil. And I'd love some comments.
Sorry, John.
Oh yeah, go ahead, Neil.
One other one was one other one is CA125. So we get hundreds of patients with CA125s who are premenopausal, and I know Professor Gordon Ruston always said that we shouldn't really be doing CA125s on premenopausal women because they change with the menstrual cycle, and you get slightly elevated ones. So anything over 30 gets automatically referred as an ovarian cancer patient, even though they're very much premenopausal. And then we have to organise a scan and assess them from that point of view. So that's the other group that is, and often they'll have endometriosis and have nothing to do with endometrial cancers, but those are the ones that do put a huge amount of pressure on us.
Great. The CA125, I've got quite a few slides on that, which I think would be of interest. But in terms of the referral criteria and how people find this form and patients they're referring, can any GP colleagues on the call comment at all? And also, I know it's great. We've got Abs, who runs a non-specific symptoms clinic. I can see online as well. So anyone got any comment they can make about what referrals from primary care and use of the 2-week wait form in gynecology? Abs, are you able to comment at all from your experience? Because obviously I know you see a broad range of referrals and are familiar with the patients perhaps who don't fit the 2-week wait form and the use of it.
Thanks, John. So we use CA125 as a kind of filter function test for patients that are referred to the Rapid Diagnostic Centre. For those with non-specific abdominal pain, it is helpful, and it's more of a case of which we do not want to add an extra step to the pathway. If we are worried about a gynae cancer, then absolutely should be seeing our gynecological colleagues rather than coming to us. I think when it comes to a GP sitting in primary care and we're worried about abdominal pain, I totally echo the sentiment of that we have to keep a broad range of differentials here, that it could be lots of things going on, benign and malignant, and you know, I do find the CA125 helpful in context of other symptoms as well, but you know, sometimes advice and guidance has been helpful for me as a practicing GP if I'm not sure. Sometimes picking up the phone to a colleague as well. But putting in as much detail in this form has always been the way I've tried to approach things.
Thanks very much, Habs. And certainly we'll come on to mention about the advice and guidance system that Neil kindly had a chat about last night, which is a source of advice for patients who are not sure where they fit in. Does anyone have anything that they, in terms of this form, we're revising it at the moment, that you would like in it? Yes, hi, please go ahead. I can see a physical hand up. Hi.
Yeah, hi. It's Brando Vinayak. I'm abroad at the moment. Question to you. I mean, one of the problems that GPs face, we understand, except what you're saying about referrals and the 2-week rule, etc. But one of the things we face is if you were worried enough for a patient, but not 100% sure it's cancer, we never are 100% sure, but suspect it's a high risk of cancer, we are more prone to send under TWR rather than send to an urgent referral, because we don't know when the patient will be seen under urgent referral. If in the past we used to get waiting time lists saying gynae, urgent referrals, 3-week wait or 4-week wait, etc. That seems to have disappeared, right? So if we had a better idea of when the patient is likely to be seen, then that urgent referral pathway could be followed rather than TWR pathway.
Yes. And I think that reflects, and Neil, I don't know if you want to come in on this at all, that the pressure's on the service and it's less easier. And I know you're running extra urgent clinics to see these patients that aren't true 2-week wait, but do need to be seen soon. Neil, does anyone else want to pick up on that? Okay, so I'm going to go on to CA125 next.
Sorry, John, can I just come in? It's Kate Wilson. I'm service manager for Gynae. So
hi, Kate.
Hi, yeah, sorry to interrupt there. Our urgents at the moment are within 3 to 4 weeks, so there is no issue with our capacity for the urgent gynaes at the moment. So and Rego Vantage, on average, it's a 1.6 turnaround in days, so they are viewed every single day. We get about 10 every day, so it's like a clinic's work every day that the consultants see. So it's definitely the right route to go to for Rego Vantage. If anything changed, then obviously we can get in touch. We do have a task and finish group that we could let the teams know if there's any issues with the capacity from that end.
Great. Well, that's really good to hear, Kate. Any other comments before we move on to CA125? Just monitoring. Okay, so CA125, the charities and nationally, there's obviously a lot of attention on CA125 and any woman who's got vague abdominal symptoms having investigation for it. And you obviously have these slides shared, but CA125 can be elevated in a range of conditions. Next slide. Thank you. There was this superb paper. I lead the clinical advisory panel at Cancer Research UK, and on that panel are Willie Hamilton and Fiona Walter, who are academic GPs, and looked at the national data set on performance of CA125. And I think it's a really interesting study to look at. Next slide. And this looked at patients with a CA125 over 35, so that meets the criteria for the 2-week wait clinic. And of the patients having the test, 7.5% under 50 it was elevated, and 6.4% over 50 it was elevated. So we know in lots of young women it will be elevated due to menstruation or endometriosis. Interestingly, in those for whom it was elevated under 50, only 0.4% had ovarian cancer, but 0.8% had non-ovarian cancer. So it's interesting, in those for whom it was elevated, actually, and they ended up with cancer, they were more likely to have a non-ovarian cancer than an ovarian cancer. So it's important if someone does have one elevated, not just to think of a pelvic scan. And if we look at the postmenopausal age group, likewise, they 1.2% with elevated CA125 had an ovarian cancer, but again, more than double the number who eventually had cancer had a non-ovarian cancer. So I think it's just important to bear in mind that CA125 is not just about the ovary, it's actually a peritoneal marker of other cancers as well. Next slide, please. This is, I think, a really useful bit of information which I ideally would like to be incorporated into future iterations of the 2-week wait form. This shows the probability of ovarian cancer. Remember, NG12 gave a 3% cutoff and a woman's age. Sorry, the CA125 and risk of ovarian cancer. And we can see a 3% risk of ovarian cancer is only really met when the CA125 is over 50. Oh, so there's a question there I can see. Do you want to go ahead with your question before I go on?
Yeah, hi. I was just
Hi.
wondering about raised CA125 with a normal pelvic scan. How much would you advise we do after that?
Abs may want to comment on this, doing a multidisciplinary clinic. I think the data we certainly got from the UK CTOC study and others is it's often the velocity of change in a CA125, which is important. So some people's background CA125 level is high. If it is 40, I wouldn't be particularly worried, but I'd probably recheck it. If it is very elevated, so over 100, I would recommend probably doing other tumor markers and an ultrasound scan of the abdomen, potentially chest x-ray as well. But Abs, you may have comments on how you would manage that from your rapid diagnostic clinic.
Thanks, John. I think velocity of change is incredibly important here, and I think if it was raised, if we had a patient that came to us and we had a particularly raised CA125 in the absence of ovarian pathology, we would be looking for something peritoneal. So would be looking at some kind of cross-sectional imaging within the RDAC if it was significantly raised and there was velocity of change there. So it's far easier to kind of coordinate those tests within secondary care. So I would say within primary care, if things are particularly raised and you don't think this is a gynae cancer, please do refer on to your local RDAC.
Great. And next slide, please. So feeding into that, we found that there was, with a CA125 level, this is across all patients of 17, in fact, there's a 3% risk of any cancer. So that is actually a marker for other cancers as well, which we've just talked about. And the next slide. And this is something that ideally I would like incorporated into future 2-week wait forms, is that the risk of ovarian cancer and the CA125 level varies significantly with age. So for a woman who is 50, for her to have a 3% risk of ovarian cancer, her CA125 would need to be over 60, whereas for a woman over 70, the level would be around about 30. So just an appreciation that we've got a lot of data about CA125, that age is very important. Any comments on that in your use of CA125 in the community and experiences you may have had? I mean, I think particularly in young women, it's used a lot and can create a lot of anxiety. Next slide, please. So other things we just wanted to mention was that I've talked about, so obviously the CA125 in premenopausal women. And the question about women who are not fit for any treatment and appropriateness of referrals. So sometimes you've got a very moribund older patient. I know I've heard from colleagues that these patients come into clinic if they're not going to be fit for any investigation or treatment with the appropriateness of that. Women taking hormones, being at HRT or on the pill, intermenstrual and postcoital bleeding, there is good guidance out there for managing HRT. I think a lot of the body identical HRT that's used, utrogestan, can offer slightly inadequate stability to the endometrium. So you see a lot of women with breakthrough or irregular bleeding on utrogestan, and often a pill change will alter things. And intermenstrual bleeding is very common. I think one thing that is vital is that somebody examines the cervix, and we're going to come on to that in some of the case studies later. Vulval itching, we're going to discuss that as well in a moment, but usually that's clearly not a malignant cause. And as we talked about earlier, there are advice and guidance services that are available that can be used to discuss whether or not rapid access services are appropriate. And next slide. And Kate commented on this, that certainly at Hillingdon you're able to get advice back within a 2 or 3 working days, and this is available across North West London boroughs. I don't think it's available in, I don't think it's available in South West London. I don't think it's available in my patch at the moment, but I know that there are challenges in terms of clinicians' ability to respond to this, and I think it's, you know, it's going to probably be and something that needs to be better incorporated into secondary care job plans from discussions that I've had. I can see a raised hand. Who's does someone want to comment?
My name's Dr. Shams Watson. I'm a GP. I think it would be really helpful that we had CA125 with a chart to age like we do for PSAs. Yeah. I was unaware of quite how low the risk, age 40, of CA125, and I'd have to question whether we're even wasting pathology time doing so many in the younger people, because it is just because you know, a lot of people are going to be made very anxious with achieving not very much, isn't it? So I mean, if we could have something put beside the ICE to question whether we should be doing it at all in the under 30-year-olds or under 35s, I think that might be quite helpful, actually.
Yeah, I mean, it does create a huge amount of anxiety, and young women will have functional cysts. I think I've got a cyst, I've got a CA125 at 50, I've got ovarian cancer. Neil, I can imagine you've got a lot to say about this. I can see your hand up.
Yeah, I was just more, the CA125 is one aspect. I think that we've reached on the HRT and the problem with, so a lot of people are starting women on continuous combined HRT too early, who then end up having very irregular bleeding, which is a side effect of being of continuous combined HRT. So in those women who are 2 or even 3 years postmenopausal should probably go on cyclical regimens and not go straight on to continuous combined, because they do end up having very irregular bleeding, and we end up seeing a lot of those, and the increase in HRT is causing, again, a huge problem within the clinics. And if they went on to cyclical, had a regular bleed, then that would negate them having to come up for scans or anything else in that context.
Yeah, I mean, I'm a huge fan of Mirena coils, Neil. I don't know if you use a lot in your practice as well.
Yeah, no, Mirenas are another option for them, but there is evidence that Mirena coils do have a slight increased risk of ovarian of breast cancer. So there is some element of that. So long-term progesterone may not be quite as benign as we think.
Great. I'm aware that we need to move on to the next section on cervical screening. If there are no other hands up, I will hand back to Lindsay to talk about screening.
Thank you, John. So next slide, please. So the cervical cancer screening programme is a national programme. I'm not going to teach everyone to suck eggs. I think we all know what it is, and we know the ages that it is targeted at. As we know that there's an NHSE, so it's an England initiative for letters to be sent out to our patients. And as of October last year, they expanded that text reminder project to include those that had not been screened within 18 weeks of an initial contact. So they've got double the contact now as well. And then we as practices are asked to proactively contact the non-responders. We know that women are less likely to attend an appointment as part of COVID pandemic. So we already knew it was a struggle to get our targets, and now it's even harder to hit those targets. So practice staff are encouraged to reassure patients that lots of measures have been put into place. Of course, that's the same as all our face-to-face contact, really. And the final box talks about PPE. Next slide, please. So this is about the screening rate. This is the performance as of February, so a couple of months ago. And as you can see, the younger cohorts of patients are more of a challenge and have always been. This is the same data as always, really. Our older patients are slightly better to engage with, so that doesn't really surprise me. And obviously the deprivation can certainly affect that, and I'm going to talk about some health inequalities and opportunities to address health inequalities in a moment. But that's just at a Borough breakdown to give you an idea really of how we're all doing in relation to each other, but all pretty similar. Next slide, please. So these are general opportunities for improving your uptake. So cervical screening campaigns, patient videos, there's a quality toolkit. We've collated a lot of the screening initiatives in West London as part of the RMP West London Alliance. So that's all in one presentation, which we've embedded in here. And then there's a lovely cervical screening barriers document that one of our cancer clinical leads and other colleagues in West London produced for us. So we've embedded that in there as well. It's a nice document, something to look at. Maybe there's a barrier that's relevant to your practice. The next slide, we'll look at health inequalities. So this is for specific cohorts. So as you can see, we're focused on transgender, learning disabilities, non-responders, mental health. So these are opportunities where you may have a specific cohorts that you would like to focus on. As we know, the DES this year has a specific mention on health inequalities. So we thought that this might be quite helpful. RMP are going to be organising training for primary care teams to support the understanding of trans men and non-binary. So that's something to come. And use our patient participation groups could be a good opportunity to raise cervical screening in specific cohorts and groups. Next slide, please. So I've just got some examples. I've got 3 practices that we're happy to share what they've been doing. So this was the Wideway surgery down in Southwest London, Merton. So they increased theirs by producing an Eventbrite as a mechanism for patients to book an appointment online, and they proactively text these patients. So as you can see, out of the 686 patients that sent a text message, 251 received the message, 27 were booked in, 21 attended. Lessons learned is confirming contact details. That's a big one. A lot of contact details are out of date or incorrect. And then the PCNs offer capacity at weekends. So that's one way, Eventbrite and check-in details. Next slide, please. In Hounslow, they focused on hard to reach schemes. So they focused on patients that had not had cervical screening in the last 7 to 10 years or had never had a cervical screen. And what they did was they incentivised their practices for those that did go on to have a successful screen. So they had an additional 1,319 cervical screens for patients that had never had it or had had a delay of 7 to 10 years. And it's actually was so successful that it's part of their contract for 2022-23. So that's Hounslow financially incentivising their practices. And final one is Croydon, and this one's quite interesting. So they've got a specialist service that's being delivered in Croydon, manages those patients who are nervous and anxious about cervical screening, from reasons ranging from a bad experience to previous abnormal requiring specialist advice or treatment. It's been running for 2 years now with a very high attendance rate, and we've picked up on this at Royal Marsden Partners, and we're thinking that we're going to be training, we're going to get some training delivered by the specialist nurse that's delivering these clinics because they're so successful. So coming soon. So from these case good practices, we've seen opportunities where we can support further. Next slide, please. These next 2 slides are summaries of how to produce automatic bookings for your patients. So you could text with a reminder for cervical screening, but then also how an opportunity for them to book in directly. So this stops them having to ring the surgery and go through the receptionist and wait online. They can just automatically book or automatically cancel their bookings. And we know that this has been successful when implemented. So I've got a slide on EMIS with some screenshots, and the next slide, please, has how to do that on System 1. So again, after the presentation today, we're going to circulate this. So should you want to set this up at your practice, this would be how you would do it. Hopefully they're helpful. Next slide, please. So in North West London, we have new screening improvement facilitators. So these are two colleagues called Anna and Jennifer. You may or may not have had contact from them yet. Now, they're RMP commissioned and they're through Community Links. So that's Community Links is the same one that has been supporting us with our bowel screening and contacting our patients for bowel screening. So Anna and Jennifer are part of that team. So they're going to be working on looking at PCNs and practice screening performance for all the different screening programs. And then they're going to work with all of us GP cancer leads and individual practices. So you see they're going to be looking at cancer data, they're going to look at bringing discussions, strengths and improvements, sharing best practice and supporting action plans. Next slide, please. So what have they been doing so far? So they're new, they've only been around for about a month now, I think, a month and a bit. So informing practices of the Joe's Trust cervical cancer prevention training. They've been providing videos and leaflets in several different languages. Information on the extended access hubs and how to use those to deliver screening, cervical screening, providing info on EMIS and System 1 and the self-book, so the two slides that I just showed you previous, and info on how to use Eventbrite for your patients to book into cervical screening. So Anna and Jennifer will be reaching out to those practices to support. They're really focusing on those who are have more of a challenge with delivering on screening and achieving their screening metrics. So they'll be doing outreach specifically to certain practices, but should you have something specific, their emails are in the slide deck, so you please use them, but they're a finite resource and unfortunately, so they will be targeting their supports where possible. Next slide, please. So what are we doing as the Cancer Alliance for West London? So some initiatives for us. We're supporting sample takers. So some sample taker training for cervical screening, and that's via the North West London Training Hub. So there's the contact details. Katerina would be delighted to hear from you. And obviously we need mentors and accessors to look at what the sample takers are doing. So again, Katerina would love to hear from anyone that would like to be supporting that and getting involved. So that's the details on sample takers. Next slide, please. So extended access hubs. So like I mentioned, RMP have been providing funding to the federations and PCNs in North West London, and the funding comes to an end. It comes to an end in September. So on more information on that, do contact your borough cancer leads. So that'd be myself for Brent and Ealing, but you each have your own borough cancer lead for that. Some federations have developed some videos for the boroughs to help with promotion of cervical screening with specific cohorts in different languages. And they're all available on our YouTube channel, so please go there if you want to have a look at those. There's some videos produced by Ealing, the Belmont medical practice. So we've got them in Punjabi and English and Somali. So please use those. These are short videos that can be sent to patients, or you can put them up in your practices. And then there's also a dedicated cervical screening clinic for trans and bisexual as well. So please do have a look at that as well. So all of these are hyperlinked, so you can connect to them quickly. Thank you. And then cervical screening and the new PCN enhanced DES. So from the 1st of October, as we know, PCNs must provide an enhanced access service from 6:30 to 8 PM Monday to Friday and between 9 to 5 Saturdays. So we have produced a one-pager on how you could put cervical screening in your extended hours, some clinic options, what the PCN needs to do, and a bit on sample takers and training if you wanted to do this. It's optional, but it would be a nice opportunity. As you saw, all boroughs have a challenge with cervical screening metrics. This could be your opportunity to increase your practice and your PCN metric. Thank you. Next slide. Next slide. And a little bit more health inequalities. So all in one place to really help focus and support your PCN early cancer DES, specifically looking at health inequalities. So touched on this earlier on, a little bit more here where we've really collated everything for you all in one spot. And that's from me. So now we're going to go to the case study. I'll hand you back to John.
Super. Thank you so much, Lindsay. I know we're running slightly short on time. I can see some questions in the chat, and Neil's kindly answered about the progesterone. So synthetic progesterones vary in their risk of increased risk of breast cancer. Utrogestan, which is bioidentical or body identical to native progesterone, is thought to have the lowest risk. We've got a few case studies which hopefully will work on a Teams poll. So the first one you can read there. So 53-year-old woman, last period 6 months ago, abdominal pain for 3 weeks, no other symptoms or signs, and the same sexual partner for 20 years. What would you do? So just click. I assume you can click that somehow. Is that right? Here we go. Okay, so great. So hopefully something has come up on forms that you can decide what you would do. We've got 8 responses so far. Okay, we'll just give it a couple more seconds. Okay, I think we will call the poll to an end there. I don't know if that, do the things appear somewhere? Okay, I don't know if I can see, perhaps someone else can see the results. Can anyone see what people answered?
I can see them for you, John. So 52% said undertake investigations now, 41% said ultrasound and CT, 5% said secondary care referral.
Okay, so the problem with this study is obviously we're talking about ovarian cancer and referral and symptoms, and you're an engaged and clever group of GPs. This actually vignette was part of a study that I was involved in the research group I lead. Next slide, please. And we published this. Peter Rose, who's an academic GP at Oxford, led the research, and we compared the responses to this question to GPs in the UK and other countries we deal with. Next slide, please. What we found when we conducted the survey, and it was amongst the noise of lots of other vignettes, so it wasn't just to talk about ovarian cancer, what would you do, which obviously slightly muddies the water, was that GPs in England, fewer than 40%, so we've got England, Northern Ireland and Wales, so the formatting's just changed a bit, fewer than 40% would refer compared to New South Wales, Ontario, British Columbia, and all those regions had much higher ovarian cancer survival. So we know obviously it's associative, not necessarily causative, but that there was an association. Referral patterns appeared to be lower, and we did this across a range of cancer types in the UK. And also GPs in England, this was back in 2013 when we did this, were less able to get specialist advice compared to other countries, but obviously things are changing. Next slide, please. Okay, so these are pictures of a cervix or different cervixes. Which one would you refer to Neil Watson's clinic? So which one would you refer to a 2-week wait clinic? Julie, you've got a question there.
Yes, my question is from the question before. What would you want us to do? A 53-year-old tummy pain, is there a 3% risk of that being ovarian cancer, or is it more likely to be a UTI, renal stone, IBS? I mean, I can't believe that you would allow me to refer with just that.
Mm-hmm.
I mean, you would say, have you done a CA125?
Exactly. So the interesting thing was just doing the similar. So I guess that would be undertake investigations now.
Yes.
Would it be an answer C, rather than referral?
Well, you would do C. I mean, I can't believe as a system you could allow us, your secondary clinics are going to be too busy if we just referred you all of them.
That's certainly not the suggestion of this. This was just, it was a vignette to look at patterns of behaviour internationally. So, but
we do know that Poland, for example, they scan everybody, don't they? And we are fighting against the culture that expects us to scan everybody. And so I'm aware that there's this tension. But if the newspapers and now you as the specialist are saying, I actually need to be doing more scans, I just needed to clarify if that's what you're asking us to refer more people with tummy pain.
I don't think it's about referring more. I mean, this is just a short bit, but I guess it is organising appropriate investigations. And we know we've probably got the most data about lung cancer. If we look at variation up and down the country in use of X-rays, and there's huge variation in up and down the country. We know practices that undertake more investigations, there are a greater incidence of early stage pickup, which is, I guess, kind of inevitable. So it's not to say that these patients should be referred. I don't think this patient would merit referral to secondary care, but they may or may not merit investigation at that point, or they may merit watchful waiting to say, well, it's probably nothing. We'll check you for urine infection, examine you. If symptoms don't go away, come back and see me in a few weeks' time. So I don't think there's not a right and wrong in this answer. This was more just to get a flavour, and a long time was spent looking at these vague patients as to what patterns of reported patterns of behaviour are, not to say this is what one would do. There's not, I don't think there's a kind of right and wrong answer in this. All are right, but it was just to look at patterns of behaviour. Does that make sense?
I mean, that's great. So fantastic.
Great. And there's another hand up. I hope you're all responding to this to the form here.
Yeah.
Hi.
My name is Navin Thakra, GP in Chiswick. I think it would really help with modern times to have locality clinics for ultrasound and probably regular gynec outpatient clinic in the community rather than at the hospital, to save time and to expedite the investigations, particularly like ultrasound. We don't want to send everyone with suspected cancer straight away to 2-week rule. And I think we used to have the services before, but now to get a normal ultrasound, it takes weeks and weeks and weeks.
Yeah, so welcome any other comments on that, but I think you're absolutely right. I mean, we know that access to high quality ultrasound scan in a timely manner is going to be vital, not just for gynae issues, but for other issues as well. So I mean, I agree. And there's going to be a new cancer strategy launched, and part of that, I know from stuff we're involved with, is about greater rapid access to imaging. And what they've done in Denmark certainly is more of these yes/no clinics that GPs can access to say, I just want to scan quickly, and then almost put it to bed. Okay.
For example, we got 5 PCN in Chiswick, and our population in Chiswick is about 55,000. So if you get a localized thing in each region, it would, or at least 2 or 3 regions where patient can access rather than waiting, and the GP can basically get this sorted out.
Yes. Yeah.
Thank you.
Thank you so much. Thank you. I'm conscious of time, so thank you for your responses to this. Bala, should you want to make a comment? Balish?
Hi. I just want to say, sorry, can you see me? Sorry.
We can see something. I don't know.
Can I just say, I just want to say thank you so much for the talk, and they more likely to listen to you, whoever the policy makers are, than we as doctors, as GPs. Maybe you could, the last colleague was talking about doing things in the community and have better access to ultrasound. These are brilliant ideas because it does work. So maybe if it comes from you, they're more likely to get done. So just wondering if you could do that.
I mean, it's not. I think what tends to be effective is people coming together with this, saying this is important. And I think there does appear to be a groundswell that access to rapid access to diagnostic imaging is crucial. So I think everyone acknowledges that.
I don't think they do listen to GPs, so that's what I'm asking. You're the specialist. If it could come from you, maybe.
Okay. Well, we're all working together. Abs, did you want to come in?
Yeah, I'll just come in. So I'll just pop something in the chat box about this in the context of time, but any issues with this you can pick up with me offline. Thank you.
Thank you, Abs. So these are picture of services, and just to talk through what they are. So A actually is a cervical ectropion. Actually, it can be very difficult sometimes to distinguish an ectropion from what something could be malignant. Slide B is a cervical cancer. Slide C is a benign polyp, but the only way it's benign definitely is removing it. Slide D looks very abnormal, but actually it's a woman with cervical atrophy. And slide E is a normal cervix. It's not an ectropion, but just with the speculum, you can see the transformation zone. Okay, next slide, and I know we're going to have to finish up in a moment. So another quick fire. Which one would you refer to 2-week wait clinic of these? Okay, so just letting the poll come in. Almost exciting as Eurovision. Okay, so I can see everyone is responding to say C, which is great. So we can see in slide A, those are vulval condyloma, warts. Slide B, lichen sclerosis, and slide C is a squamous cell cancer on the background of lichen sclerosis. Okay, next slide. So I think that's all from me. Lindsay, I don't know if you wanted to sort of close up, because I'm aware we're slightly running out of time. Apologies.
No, thank you. I love good case studies. I hope everyone did. And I just wanted to wrap up really. So just to thank you, John Butler, for joining us today as our specialist. Thank everyone for participating and making this a more interactive webinar. The slides will be sent out and the recording will be available on our YouTube channel. But you can email us if you want the presentation. So there's our email. There is a smart survey, so please do complete that for us, so as we know what we want for future webinars. I know case studies are always an ask, so we always try and include those where we can. And the next one is on the 14th of July. It's our hot topics. So thank you all again for joining us. Thanks our MP team for bringing this all together. Thank you, John.
Great. Thank you. Nice to meet you all. Have a great day.
Thank you.